First of all, let me thank Dr. Lita for inviting me here. So the topic given to me is ocular hypertension, to treat or not. One of the very common dilemma that all the clinical ophthalmologists face when we sit in the OP. So a patient comes, either he can be a younger patient with two scenarios I have shown here. So either a very young patient or an old patient coming to you with all the other parameters being normal except the intraocular pressure, like being either outside the normal limits. So it can be either in the lower range or in the higher range. So you get confused as to whether to start or not. Here the only abnormal parameter being the abnormal intraocular pressure, high intraocular pressure. So to start treatment or not, that is a complex decision. And it depends mainly on the presence or absence of various risk factors which have been identified by various clinical studies that have been conducted on OHT patients. So let's see what is an ocular hypertension. So it has to fulfill the following criteria, like an intraocular pressure greater than 21 millimeters of mercury or in one or both eyes as measured by applanation tonometry on 2 or more occasions. But the glaucomatous visual field testing shows absence of glaucomatous field defects. The optic disc and nerve fiber layer is normal. The angles are open, and there is an absence of other ocular conditions which can cause a secondary elevation of intraocular pressure. So the only abnormality being the high intraocular pressure. So the risk factors have been identified by various studies. I have just named the few studies, that is the older studies like Barbados Eye Study, the Rotterdam Eye Study, the Melbourne Eye Study, then coming to the familiar ones, that's the OATS and the EGPS. So the risk factors have been identified as a family history of glaucoma, a thinner central corneal thickness, a lower ocular perfusion pressure, then the use of systemic calcium channel blockers as in Rotterdam Eye Study, use of systemic alpha agonist blockers, large CDR, large CDR. All these have been identified. So you have to look for these features when you see a high intraocular pressure. A few words about the European Glaucoma Prevention Study, which tried to evaluate the efficacy of reduction of IOP by dorzolamide in preventing or delaying POAG in patients affected by ocular hypertension. It was a multi-center randomized trial with 1,081 patients from 18 European centers. The age was greater than or equal to 30 years with intraocular pressure 22 to 29 millimeters of mercury and visual fields and optic disc being normal. And the patients were randomized to two arms, a treatment arm with dorzolamide and a placebo arm. But the finding after 5 years was that dorzolamide reduced the intraocular pressure by 15 to 22%. And the placebo arm also showed a reduction of 9 to 19%. And the EGPS could not show any statistically significant difference between the medical therapy and placebo in reducing the incidence of POAG. But it could find out some predictors for the development of POAG in OATS and in EGPS. That is the same as in OATS, like older age, higher IOP, thinner CCT, larger vertical cup disc ratio, and a higher PSD in the HFA. So this OATS is the common study that we all know of. It had 3 phases. It started in 1994, and the first phase was for 7.5 years. So 36 patients were randomized to a medication group and an observation group. And at the end of 7.5 years, the objective was to determine the cumulative incidence and severity of POAG after 20 years of follow-up. That is all 3 phases together. OATS has phase 1, 2 and 3. And the patients were like 40 to 80 years old patient with intraocular pressure in one eye of 24 to 32 millimeters and a fellow eye with 21 to 32 millimeters of mercury. Then visual fields and optic disc had to be normal. But the phase 1, the goal was to find the safety and efficacy of topical treatment in delaying and preventing the onset of POAG in ocular hypertensive patients, and also to determine the various clinical and demographic factors which can predict the which patient would or would not develop POAG. So at the end of 60 months, the cumulative frequency was 4.4 in the medication group and 9.5% in the observation group. So it clearly proved the protective effect of treatment because it was statistically significant. And it also showed that it is necessary to monitor both functional and structural parameters because the early glaucomatous changes were detected in optic disc photographs in 2/3 of cases, whereas the visual field test was abnormal in 1/3 of cases. In the phase 2, the observation arm, the treated arm was actually continued, the treatment was continued, and the observation arm patients were started treatment. So there was an early treatment group and a delayed treatment group. And again, the incidence was calculated, and the cumulative proportion of patients who developed POAG in the original observation, that is the delayed treatment group, was slightly greater, that is 0.22, and in the early treatment group was 0.16. And it was also shown that the penalty for delaying treatment is minimal for low risk patients and it is more for high risk patients, which suggests that high risk patients may benefit from more frequent examinations or follow-ups and early treatment, but low risk patients they can go around without treatment but with monitoring, but not at that frequent intervals. And it was also shown that Afro-Americans had a higher incidence of glaucoma. And the phase 3 was again evaluated, and it was shown that the cumulative 20-year incidence was 45.6%, with 25.2% of patients developing visual field loss in one or both eyes after adjustment for exposure time. So it's important to start treatment at an early stage, but identify the patients who needs treatment and regular frequent follow-ups. So the risk factors identified in the various studies I have just listed, all of you must be knowing: consistently high IOP, thin CCT, vertical CDR of greater than 0.7, older age, abnormal visual fields, optic disc hemorrhages, severe unilateral glaucoma, that is the fellow eye of such a case is high risk. Then family history of glaucoma or genetic predispositions and other factors. So OATS actually, they did put together a risk calculator. So, and various risk calculators are now available, which estimate the 5-year risk of a patient with OHT to develop POAG. And the data is actually derived from these two studies, and it takes into account the age, the baseline IOP, the central corneal thickness, the pattern standard deviation of HFA, and vertical CDR. It has various methods in the risk calculators. The predictions derived using these methods are designed to aid but not to replace the clinical judgment. That has to be remembered. And it may not apply to patients who are very young, like less than 40 years, non-white patients or African descent, and without an IOP of 22 millimeters or higher. And they also do not provide critical information which may guide therapy, such as life expectancy. So, when to treat a patient? So, in the studies, actually, the patients were stratified. Using the calculators, they were stratified into 3 strata, like low risk, moderate risk, and high risk. And these patients, actually the high risk patients, always before starting therapy, you have to discuss it in detail with the patient as well as the caregiver. And you have to tell them the pros and cons of starting a treatment and reach a decision. So high risk patients, you should suggest that treatment be initiated, and you should tell them the disadvantages that they may face. And in moderate risk, you can start treatment, but you can also monitor closely without starting a treatment. And in low risk, actually, you can, without treatment, you have to monitor them, because monitoring is very important in OHT patients. But in one-eyed patients, or when you cannot record a visual field, or when fundus examination is not possible due to some corneal opacity or other factors, then it is better to start treatment in such patients. So always do a detailed patient assessment. And when you have decided on starting treatment, always select a medication that will achieve the intended target IOP range. And the therapeutic goal should be an IOP reduction of at least 20%. And cost and convenience also should be considered. And nowadays, laser trabeculoplasty, selective laser trabeculoplasty is a reasonable first-line treatment option that has adherence and cost advantage for patients. This is the LIGHT trial which compared the SLT with eye drops, and it found out that it is more cost effective, provide drop freedom to 74.2% patients, and a reduced number of glaucoma surgeries and very low rates of adverse events. The safety profile of SLT remains very good with no sight-threatening complications. So if available, SLT is a very good option. Now, how will you follow up such patients? Regular follow-up is essential to determine if there has been a change in IOP, the optic nerve head, or the visual field status over time. And low and moderate risk patients, they require not that frequent follow-up. So you can follow them up every 6 to 12 months. But patients with high risk have to be monitored much more closely. And glaucoma suspects, where you have started on treatment, always see them more closely till the target IOP is achieved, and after which you can make less frequent follow-ups. And at each visit, you should assess the IOP and always document whether the appearance of optic nerve head has changed since baseline. And visual fields also should be done every 6 to 18 months and compared with the baseline measurement. And gonioscopy also should be repeated if there is a suspicion of angle closure with any other angle abnormality. Thank you.
Thank you, Dr. Girija, for the excellent talk. It's always a confusion for us when you have a patient with OHT, and she has clearly mentioned how to go about managing these patients. I invite comments from Dr. Gauri. Can I have a mic, please?
Talk which was very comprehensive. So I don't think I have anything really to add to what Dr. Girija presented.
Thank you. Okay. We'll now go to the, may I have one question to Dr. Girija? I mean, in our country, I mean, patients, you know, like say, as you said, high-risk patients, you can tell them to come, say, I don't know, 6 months,